Hello, everyone. My name is Lance Ray here in beautiful Denver, Colorado. Excited to present to you this evening on the treatment of ventricular dysrhythmias. I have no relevant conflicts of interest to disclose. In fact, there hasn't been a new antiarrhythmic medication to market in 25 years, and I'm certainly getting paid by nobody in this space. So our objectives today are as follows. These are to satisfy CE requirements, so I will go to the next slide, where we have our more official outline here. We'll discuss mechanisms and etiology, where ventricular dysrhythmias come from, essentially. We'll touch on synchronized cardioversion versus defibrillation, something that pharmacists don't think or talk about a whole lot. We'll discuss stable ventricular tachycardias. We'll talk about torsades for a few slides. We'll go into pulseless VTach and VFib, kind of the heart of ACLS. And finally, we'll wrap up with some strategies for refractory ventricular fibrillation. So this is my favorite schematic. You may have seen it before. This is how I classify dysrhythmias. And this, I think, is the proper way to think about them. We have essentially all possible arrhythmias here, 98% of all arrhythmias. So first, we classify them into tachyarrhythmias and bradydysrhythmias. These are based on objective findings, right? The heart rate. Then within tachydysrhythmias, which most arrhythmias are, we further divide these based on another objective finding, the QRS, which we have on the EKG, the 12-lead EKG. We ask, are these wide or narrow? Wide QRS tells us that there's some delay in the ventricle because the QRS is slowing ventricular conduction. Again, no one ever knows what dysrhythmia is actually happening. So we describe it in these terms. Is it tachy? Is it brady? Is it narrow? Is it wide? And this is essentially the best way to classify an arrhythmia, is describing it. As I always tell my residents, you can never be wrong if you say, oh, that's a wide complex, that's a narrow complex, that's fast or slow. It's regular or irregular. That's the basis we form for classifying dysrhythmias. Of course, there's this term SVT with aberrancy, which is kind of an oddball term. We'll discuss that more in detail in a minute. Well, we can't talk about ventricular dysrhythmias without first talking about premature ventricular contraction. So bear with me here for a second. First, I say normal is narrow. Why is a normal QRS a narrow complex QRS? Because in normal physiology, the SA node initiates electrical conduction. It contracts the atrium. Afterward, the signal is propagated down through the His-Purkinje fibers that are designed to conduct electricity quickly and efficiently. These fibers carry electricity throughout the entire ventricular myocardium, resulting in a fast or narrow QRS. A PVC, on the other hand, is an ectopic beat generated somewhere in the myocardium. When this ectopic ventricular impulse occurs, electricity produced does not have a clear path to follow, so it travels slightly slower across the ventricle, like in this lower schematic here. Nonetheless, it results in a ventricular contraction, of course, with a wide QRS. So why do these happen? Why do PVCs occur? The myocardium is usually irritable. It's closer to its threshold action potential for whatever reason. It can be a sign of electrolyte imbalance or a sympathetic surge. It happens in young folks. It happens in older folks, more commonly in older folks, and certainly ischemia. So PVCs can be unifocal if they generate from the same area, or they can be multifocal, indicative of generating from different areas of the ventricular myocardium. Of course, multifocal PVCs would be a more problematic sign. So I love definitions, and the definition of VTach is at least 3 PVCs occurring in a row. This indicates the impulse being generated is happening now in a loop fashion or reentry. Ventricular tachycardia is monomorphic, is therefore arising from a single reentry mechanism. VTach can be polymorphic too, and the reasons behind this are a little more complex, but the reentry pathway is probably involving multiple areas or larger areas of the ventricular myocardium. Lastly, another definition, sustained VTach is VTach lasting at least 30 seconds Of course, if it hasn't been cardioverted first. I want to talk about causes associated with our major presenting rhythms in cardiac arrest. Out of hospital cardiac arrest is how we frame the discussion because that's where the majority of the literature is, and that's where the majority of cases we deal with from the ED. Overall survival is 10% for all out of hospital cardiac arrest. Not great. Pulseless VTach, VFib, PEA, and asystole are how we classify these presenting rhythms. So working our way up, asystole is a terrible rhythm. You can hook up an EKG machine to your computer monitor right now, and it will show asystole. It's nothing. It's lack of a rhythm. So no matter that the survival averages about 1% for this rhythm, or technically lack of rhythm. Pulseless electrical activity encompasses all of the rhythms that are not ventricular and not asystole. So it's a diagnosis of exclusion. This is really what our H's and T's were designed to look for from a diagnostic standpoint, because the etiology of PEA varies so much. Can be anything. Average survival is about 8% with PEA. Last, what we're here to talk about today is pulseless VTach and VFib. The cause of these rhythms are overwhelmingly coronary or cardiac in nature, and usually they are relatively very survivable rhythms, for 25 to 74% survival, depending on a variety of conditions. To emphasize this last point, I'm going to dump some stats on you, which really drive the point home. About a third of cardiac arrest patients will initially present with ventricular dysrhythmia. Many ventricular rhythms, especially in pediatrics, are congenital in nature. Ventricular dysrhythmias are associated with an odds ratio of 3 to 6, sometimes more, for myocardial infarction as the root cause. Likewise, half of all patients with an initial shockable rhythm, VTach or VFib, have evidence of an acute MI. And lastly, about 18% of ventricular arrests are refractory to shock. Looking at this another way, shocking patients is particularly effective and terminates most ventricular arrest rhythms. So as I mentioned earlier, ventricular tachycardia can be monomorphic or polymorphic. Monomorphic VTach is generally a result of adult cardiovascular disease, specifically myocardial ischemia or heart failure. While with polymorphic VTach, we're most commonly talking about torsades. Then we have these oddball etiologies like Brugada, catecholaminergic polymorphic VTach. These are largely genetic in nature and represent a minority of the VTach that we see. So let's talk briefly about the difference between cardioversion techniques, electrical cardioversion for what it's worth. So electricity can screw up a rhythm worse, just like antiarrhythmic drugs can, being proarrhythmic. So synchronized cardioversion is used and indicated for rhythms with a pulse, because we could very easily make these rhythms worse again. Synchronized cardioversion is when the machine times the shock right on the R wave. It actually detects the upstroke of the R wave and delivers energy right then and there. It's pretty incredible, actually. Because if we shock during the R, between the R and the T wave, we could induce torsades, VTach, ventricular fibrillation more commonly, and make it worse. So defibrillation is a term that we use. Same thing, same energy, same shock, nothing different except for the timing. And these are just random shocks. We can give it whenever. Because we need to defibrillate, need to cardiovert, but the synchronization doesn't need to be there. So I wanted to present a slide here on making sense of all the antiarrhythmics before we get into the meat and potatoes of our pharmacotherapy for ventricular dysrhythmias. So we've got all of our antiarrhythmics here, pretty intimidating, right? These are class 1, class 3 antiarrhythmics. Remember, the class 2 and class 4 antiarrhythmics are really not antiarrhythmics. They're rate control agents, right? They're beta blockers and calcium channel blockers. Those aren't going to cardiovert rhythms, or not intended to at least. So our class 1 and 3 agents are here. Lidocaine is the same thing as mixilotine. Mixilotine is a PO form of lidocaine that can be absorbed orally. Same thing down below. Dofetilide is the same drug pretty much, but it can be absorbed easier in the gut as ibutylide. I've color-coded these to make some sense of the routes. So all the ones in blue are given PO. The orange are pretty exclusively IV, and the yellow can be either be given IV or PO. So starting off, also I put a key here for atrial and ventricular rhythm. Some are indicated for atrial, some are indicated for ventricular. For example, disopyramide is almost exclusively used for atrial arrhythmias. Its niche there is atrial fibrillation in the setting of hypertrophic cardiomyopathy. We won't go through all these. I'm going to cross out quinidine. I usually cross that one out because it's not available anymore and it's not used. Propafenone and flecainide are essentially used for atrial arrhythmias, but they're only PO. We're not going to talk about them in our presentation here. These are both indicated for atrial and ventricular arrhythmias. Ibutylide and dofetilide are only exclusively used for AFib. Bertilium is mentioned in the 2020 iterations of ACLS guidelines for ventricular arrhythmia. Used to be used a lot. It's not available, and therefore virtually not used. So that leaves us with procainamide, lidocaine, and amiodarone. I put a box around sotalol too because it is available. A newer IV formulation is available and being marketed right now, but it's expensive. So this really narrows it down to our three drugs that we use for ventricular dysrhythmias: procainamide, lidocaine, and amiodarone. Stable VT. Things are stable. This was just a stock PowerPoint photo, and I just left it. This is how I prepare for a stable VT patient in my ED, smelling candles over in the corner of the room. Not really. Stable VT, even though it's stable, is, in my opinion, like the pinnacle of emergency medicine pharmacotherapy, making evidence-based decisions quick based on limited patient information. I can assure you I'm not smelling candles in the corner. My mind's going 100 miles an hour, trying to think of all the things. So, stable ventricular tachycardia, we'll do a brief literature review and then talk about some medications. There's just not a lot of evidence on the treatment of stable ventricular tachycardia. There's only a handful of randomized controlled trials, half of which use medications that are unavailable now. Gorgels in 1996 had a study with procainamide, showed superiority to lidocaine. Only had 29 patients. Ho in 94 studied 33 patients, showing that sotalol was superior to lidocaine. Those were the only two drugs that they studied in that trial. 1988, going back a few years before, with a sample size of only 31, drugs similar to lidocaine, Amgeline was superior to lidocaine. Well, of course, we don't have this anymore. And then finally, Ortiz in 2017 had the ProCameo trial, which we'll talk about a little bit more. So, I think it's important to note that lidocaine was 0 for 3 in these randomized controlled trials. All of the other medications, granted small sample sized, showed superiority to lidocaine. So the ProCameo trial was a randomized controlled trial in 2017. It gets the most attention because it's one piece of contemporary data in a sea of very little literature on stable ventricular tachycardia. People get excited about this trial. People get sometimes a little too excited, I think. So they compared amiodarone 5 mg per kg over 20 minutes to procainamide 10 mg per kg over 20 minutes. This was done in 26 centers over the course of 6 years. So they really struggled with enrollment. They finally got 74 people and patients and decided, well, we'll publish this. So, not surprising that it's underpowered. They wanted 300 and some odd patients to be able to show power for their major endpoint. Their major endpoint also creates some criticism because of it was major cardiac adverse events. It wasn't termination of stable VTAC. It was major MACE, or major adverse cardiac events. Amiodarone had more adverse events than procainamide. However, when we look at one of the secondary endpoints of ventricular tachycardia, was terminated in only a third of the patients amiodarone and 2/3 of the patients with procainamide. This was significant. However, study wasn't powered for it, and this was a secondary outcome. The most common adverse reactions were hypotension, more in amiodarone than procainamide, but of course both of these drugs cause hypotension. So with stable ventricular tachycardia, the literature is sparse. The literature is few and far between. Procainamide, many consider the best choice. However, amiodarone is a common choice. Providers, pharmacists, nurses, everyone is just more familiar with amiodarone. They know how it works. They're familiar with it in ACLS protocols, and so it's a very common choice. It's not a wrong choice. Lidocaine, however, as you saw in a couple slides before, has a weakest literature. Sometimes I feel that the niche for lidocaine is for patients that are already on amiodarone and they have VTAC that is breakthrough VTAC. And so lidocaine as an antiarrhythmic provides an additional different mechanism of action. Procainamide is already an intimidating drug because it's an antiarrhythmic. It can be used for AFib and VTAC, and it has different dosing for each. So I wanted to present this slide of just here's the dosing for procainamide, but there's a few different options here. Personally, I say give 1 gram over 30 minutes. That's not even on here, but that's essentially what they did in the Procameo trial. However, FDA labeled dosing, you can give 100 milligrams push every 5 minutes. You can give 10 up to 17 mg per kg over 30 to 60 minutes. You can also give the 100 milligrams over 5 minutes, which would be 20 milligrams per minute, and you can also give it faster. Common trivia question on some board exams is a max dose of 17 mg per kg. It's an odd max dose, but that's what a lot of providers that I've run across memorize as for emergency medicine physician board exams. Also, another max dose that's thrown out there is 1 gram. You can give maintenance infusion after the loading dose. This is 1 to 4 milligrams per minute. Be aware that there is an active metabolite. Interestingly, the active metabolite of procainamide after hepatic acetylation is N-acetylprocainamide. This actually has pretty potent potassium channel blocking activity, so this may contribute to procainamide's mechanism of action. It's been postulated. Amiodarone. There's really one way to give amiodarone for stable VTAC, and that's 150 milligrams IV load over 10 minutes. You can start a maintenance infusion after this. You can. There's very little guidance on this, believe it or not. But if the patient's you're concerned that they're going to go back in VTAC or they're still in VTAC, then a maintenance infusion is indicated. The maintenance infusion is really the only way an amiodarone infusion is ever run. This is for VTAC, for VFib. We extrapolate it to atrial fibrillation, 1 milligram per minute over 6 hours, followed by 0.5 milligrams per minute for 18 hours. Remember that the half-life is super long with amiodarone, so all the adverse effects, all the drug interactions come with that long half-life too. I always remember the adverse drug reactions for amiodarone. These are more with chronic therapy, or I should say cumulative dose of amiodarone or lifetime dose. I always try to remember that renal is the one organ that amiodarone does not affect. And our second line agent, lidocaine. We can give lidocaine some scenarios. I would pick this in a patient who's already on amiodarone, PO. Give lidocaine 1 to 1.5 mg per kg as an IV push. This usually rounds to 100 milligrams, which is a conveniently formulated lidocaine syringe, cardiac syringe usually. We can repeat this up to 0.75 mg per kg every 5 to 10 minutes to a max of 3 mg per kg. Maintenance infusion, easy to remember. This is just like procainamide, infused at 1 to 4 milligrams per minute after your loading dose. Remember that lidocaine is hepatically metabolized and renally excreted. So it's metabolized to a monoethylglycine xylidide metabolite. This is thought to retain some antiarrhythmic properties of its major parent component, lidocaine, but more often thought to contribute to the CNS toxicity of lidocaine, such as agitation, tremors, seizures also. It's metabolized by 3A50 to form this complex. However, in the critical care space, patients that are on long-term lidocaine infusions, we can monitor serum levels. We want to keep those between 1.5 and 5 mics per mil. Just wanted to present a couple odd, rare types of ventricular dysrhythmia that are usually billed as stable VT, so they're worth talking about. First, verapamil sensitive VT. What? I've seen this a couple times in kids. Each time the kid was on their cell phone, positive phone sign. So they were stable as can be. This is actually a weird, like, bundle branch block with a reentry arrhythmia, creating this odd axis deviation. But verapamil, 5 to 10 milligrams does work. I wouldn't have believed it unless I saw it. Verapamil 5 milligrams worked in this 115-year-old. It's a challenging diagnosis. We didn't diagnose this in the ED. We knew that the kid had this diagnosis previously. Another one that's probably more common that you may come across is catecholaminergic polymorphic VTAC. So this is a genetic abnormality, also a genetic type of VTAC diagnosed earlier in life. If it's diagnosed later in life, the mortality is quite high. The reason is this is a VTAC that's set off by catecholamines, therefore induced by stress or exercise. Patients are often indicated they're put on a beta blocker. This is also a challenging diagnosis, not as much though, because it looks a certain way. They call this a bidirectional VTAC. So you'll see a ventricular rhythm go down, say here, you'll see it go down, and then you'll see it upstroke. And so it's a bidirectional type of ventricular tachycardia. Some say that if you turn it on its side, it looks like a Christmas tree. I don't know, but that's CPVT. It's an interesting form of ventricular tachycardia if you ever see it. Another rare scenario where you might see a stable VTAC is in heart failure, severe heart failure. You may see it more common if you work at a hospital or center that deals with a lot more heart failure patients or transplant patients. So patients have stable VTAC a lot of times, or risk of sudden cardiac death when they've had a myocardial infarction of a large infarct size leading to heart failure. They're also prone to ventricular dysrhythmias because that border area around their ischemia in their left ventricle is just prone to reentry circuits. And again, oftentimes these patients are on a transplant list. They almost always have an intracardiac defibrillator because they're at such high risk for sudden cardiac death due to ventricular dysrhythmia. And to suppress this dysrhythmia further, because you don't want your ICD to fire, patients are put on amiodarone or sotalol, long-term chronic therapy, PO therapy. Really, at this point, they need to be worked up for ablation of that ventricular tachycardia and ICD if they're not on it already. It's been shown to be better than drug escalation. Unfortunately, these patients bypass all the antiarrhythmics and go for more procedure solutions. But if the amiodarone or sotalol class 3 antiarrhythmic isn't working, then they'll be put on a class 1 antiarrhythmic. This is the one sort of niche that I see mexiletine used, really just to provide another mechanism of action. So this type of patient comes in. They have an ICD, they're on a class 3 antiarrhythmic, they're on a class 1 antiarrhythmic, and they show up in your ED or your ICU in stable VTAC, or VTAC where their ICD is being shocking them a bunch. We don't want that. So really, if you recall our antiarrhythmics we looked at, what do we have left? We have procainamide left, and that's oftentimes the drug that we'll pick in this scenario. We could use amiodarone. They're already on amiodarone a lot of times. We could use IV lidocaine. Really, it's an open field here, but procainamide's the most common agent used in this scenario. I figured we'd spend a minute or two talking about torsades. After all, it is a polymorphic ventricular tachycardia. There's acquired long QT syndrome that can lead to torsades. Of course, this has a lot to do with electrolyte status, medications, concurrent medications. Females tend to have torsades more often, those with advanced age, previous history of heart failure, or MI. However, up to 20% of torsades cases are linked to long QT syndrome. There's still a whole lot that we don't know about long QT syndrome. It's a congenital channelopathy. The different, for example, inward potassium rectifier channel is abnormal and can lead to longer QT, leading to torsades. There's still a whole lot that we don't know. There's like 20 different genetic polymorphisms involved with long QT syndrome. We've just classified it into 3 types right now. I predict that we'll find that a lot more cases of torsades will be linked to congenital long QT syndrome. So to illustrate prolonged QT, we have a myocardial action potential with phase 0, 1, 2, 3. And we have a surface EKG with QT intervals shown here. Here are the electrolytes that move in and out during the action potential to propagate the action potential. And potassium channel blockage results in a longer phase 3. This directly causes a T wave to be prolonged. This is done by the inward delayed rectifier potassium current, which sounds fancy, but this is what our potassium channel blocking drugs do. Can you name any potassium channel blocking drugs? It's a lot of the antiarrhythmics that I mentioned earlier. Class 3 antiarrhythmics are potassium blocking agents. They are designed to prolong QT. So remember that these are the drugs that I respect. Sure, ondansetron, quinolones, prolong QT, but on the order of 5 to 10 milliseconds. These potassium blocking drugs are built to prolong the QT, and so therefore they do that on the order of 25 to 50 milliseconds. And these are the drugs that I respect with regard to having a potential to prolong QT enough to portend a much higher risk of torsades than we would see otherwise. And briefly, here's just a quick chart of very common QT prolonging medications. Our class 3 agents up here. Methadone falls kind of in the middle here. And then all of these common offenders that we get alerts for in our electronic health record. But what I say, again, is the dofetilide, the sotalol, ibutylide, and methadone especially. Amiodarone's an interesting one. It does prolong QT, but it just doesn't have that high of a risk of torsades, which sort of makes sense if you think about it in a way that we give amiodarone for a lot of our ventricular tachycardias. And if we were really worried about torsades, we would see it a lot more. There's just not a whole lot of case reports on torsades being caused by amiodarone. Again, all these drugs in there, when we talk about average QT prolongation, that's one thing. Torsades risk is only associated with QT prolongation. As you can see, amiodarone prolongs QT quite a bit. However, it doesn't have a large risk of torsades. The risk of torsades is highly dependent on a lot of things, such as baseline QT, whether the patient has QT syndrome, of course, long QT syndrome, electrolytes, drug interactions with these drugs and other drugs, and a whole assortment of things. So with any case of torsades, we want to determine first if it's stable or unstable. That is, if the patient is maintaining their blood pressure, it's stable, otherwise unstable. So for any unstable arrhythmia, we want to immediately electrically cardiovert the patient. If they are stable, we can administer antiarrhythmic therapy. For antiarrhythmic therapy, most recommend lidocaine because lidocaine doesn't further prolong the QT. Amiodarone's probably a suitable agent also, really, but only in theory. It may not be the best. So either way, we want to administer magnesium. We could administer this as an IV push if the rhythm's unstable, or over 20 to 30 minutes if stable and we have more time. Remember that magnesium's never been shown to terminate torsades, but only prevent it. It doesn't really matter. Give it anyway. Last, torsades is more likely to occur in the setting of bradycardic patients. These patients tend to have more PVCs, which can cause an early after depolarization, leading to torsades. So we want to maintain a heart rate of usually 100 or greater, either done with overdrive pacing, or we can use a pure beta agonist such as isoproterenol to increase the heart rate. So a brief summary slide of all of our antiarrhythmics we use for stable ventricular tachycardia. I added sotalol in here, which we haven't talked about a whole lot. It's recently sort of been remarketed, marketed more, mostly for patients admitted with new onset AFib that they want to cardiovert with an antiarrhythmic. Really not used a whole lot for ventricular tachycardia right now, but it may be in the future. It's certainly a available and possible agent that could be used. So remember that schematic at the beginning of the presentation, wide, narrow complexes. How I mentioned that term SVT with aberrancy. It's an odd term, but let's dive into that just for a second. So imagine that you have a patient with myocardial scarring from an MI or some form of ischemia. They'll have damage to like an area in their His-Purkinje bundle, or specifically like a bundle branch block that'll just slow down nerve conduction. This causes a block, right bundle branch block or left bundle branch block, or an interruption where electrical conduction is delayed for a brief moment. This results in a wide QRS, as you can see on this EKG strip. It also has kind of this hallmark dog ear notch in it. Say then that this same patient also develops a tachyarrhythmia like AFib. Putting these two together, this results in a wide complex tachycardia, and it can be irregular too. But it's really just AFib superimposed on a bundle branch block. But it's scary because it looks like ventricular tachycardia. This is actually even very difficult to distinguish even on 12-lead EKGs. Of all the wide complex tachycardias that present to the ED, 80% are this less concerning SVT with aberrancy, while about 20% are really VTAC. So while this is the case, always assume VTAC, especially if the patient is unstable. Just know that not all wide complex tachycardias are VTAC. But again, if the patient's unstable, assume VTAC. And this is why you'll see algorithms for wide complex tachycardia look just like this. So wide complex tachycardia, if the heart rate's above 100, the QRS is above 120 milliseconds, that defines it as a wide complex. So for stable wide complex tachycardias, you'll see ACLS, different algorithms show this exact box. Consider adenosine if regular and monomorphic. That is, this may be an SVT that we would treat with adenosine, and they have a bundle branch block or an aberrancy. But only if it's regular and monomorphic. If it's polymorphic, it could be torsades. If it's irregular, such as this, don't treat that with adenosine. An irregular wide complex tachycardia is a sign of WPW, Wolff-Parkinson-White, in the setting of AFib. And this is different than SVT with aberrancy. And this is obviously a case where you could harm someone with adenosine and cause a real VTAC. So just wanted to explain this algorithm a little bit that you'll see in ACLS, WCT, wide complex tachycardia, because it's a bit confusing. But this is why we will consider adenosine if regular and monomorphic. Maybe it's an SVT with a bundle branch block that we can break with adenosine. It's only if adenosine is not going to harm the patient like it would with WPW in the setting of AFib. All right, now moving on to pulseless VTAC and VFib. We don't ever say pulseless VFib because VFib is always pulseless. VTAC, however, can be with a pulse or without a pulse. Okay, so now we have a patient with pulseless VTAC or VFib. We switch over to the ACLS algorithms for pulseless ventricular arrhythmias. Of course, we want to administer high-quality CPR, early defibrillation, and epinephrine. These are all class 1 strength recommendations with either non-randomized or randomized trial data to support them. Remember that epinephrine isn't so much for beta-1 activity and inotropy, chronotropy, as it is for blood pressure support through alpha agonism. So after 3 shocks, we move to antiarrhythmics. It's important to understand that these are class 2B strength recommendations. Why? We'll talk about the evidence here next. But remember, the wording in ACLS is may consider. It's not a must. Remember that algorithms are suggested protocols. Each patient is different. You can adjust the protocol for the patient. That's totally within the realm of these algorithms and sort of the way that we do medicine. We don't use these algorithms every time, all the time, necessarily. Finally, the algorithms are very vague on may continue infusion of presumably amiodarone or lidocaine. But a lot of maze here. Let's look at the evidence for ventricular arrest now. There are three landmark trials in the out-of-hospital cardiac arrest space. The first is the ALIVE trial in 2002 by Dorian and colleagues. They analyzed 347 patients. Most of them were witnessed arrest. Only 27% had bystander CPR. They compared amio, 5 mg per kg, a weight-based dose. We don't typically do, but it falls pretty close to what our guidelines show. Amio, 5 mg per kg versus Lido, 1.5 mg per kg. And they looked at survival to hospital admission. They found that amio, 23% of patients survived hospital admission versus 20% in lidocaine. This was statistically significant with an odds ratio of 2.5 times. Remember this in a minute. We'll talk about this. There was a 3% difference here, right, in the two drugs that they studied to survival to admission. We'll come back to that when we look at the ALP study a little more. Secondly, Markle and colleagues, 2010, did an observational retrospective study in 95 patients. Procainamide and amiodarone were both studied, and they were deemed to be equally ineffective. So this kind of stalled out our drugs for in terms of recommendations for a bit. We didn't really know what to do with this literature. Lastly, our big landmark trial that was published in 2016 was the ALPS ROCK trial, amio versus lidocaine versus placebo. No survival difference was shown, which was their primary outcome. Lidocaine, however, did show a small signal of improvement with increased ROSC at ED arrival. We'll dive into the ALPS trial a little bit more here. So I want to spend another minute on this ALPS trial because it's our best trial to date. Here are the main findings. Primary outcome was survival to discharge. This is what they call a more patient-centered outcome than return to spontaneous circulation or survival to admission. Of course, our gold standard is survival to discharge, even longer survival, 90 days, even with neurologically intact outcomes. So interestingly, this trial was powered at 90% to show a 6.3% difference in primary outcome. This is a good lesson in stats, by the way. So cool. They reached their sample size of 3,000 to power the trial. They had 3,026 patients. But that was to detect down to only 6.3%, meaning they couldn't detect a significant difference that was smaller than that. So what if the true difference was smaller, say 3%, like we saw in the ALIVE trial, remember? If so, we could say that this trial was underpowered to detect a realistic difference. If powered to detect 3% difference, they would have had to, however, enroll like 9,000 patients. This is time and money, and this is why randomized controlled trials are so hard to execute. What is this effect size, 3%? 6.3% based off of? It all comes from previous trials. It's all arbitrary. It's guesswork, but it's estimated based on previous trials. But many critics say that they would have enrolled more patients than they should have, and that this trial was underpowered even though they had enough patients. Lastly, some other fun facts about this trial. Average time to study drug after 911 call was almost 20 minutes. So it took a bit. That's pretty quick, but it's still a while without antiarrhythmic drug. They also used a proprietary form of amiodarone void of polysorbate 80. It's this Captazole formula that some folks are familiar with in IV bag form. However, it does not exist in vial form today in the U.S. So, but hats off to them. They did this study with a polysorbate void version of amiodarone, who some think that it can contribute to hypotension in patients. So they had the best possible scenario here in this trial by using this agent. Unfortunately, it might not have a lot of external validation. Lastly, the only positive finding of this trial, which personally I think is a signal in the favor of lidocaine, was that lidocaine increased return to spontaneous circulation on hospital admission. Amiodarone did not. All right, so we don't talk about in-hospital cardiac arrest trials because there aren't many. There's about 100 cardiac arrest trials out there, only 5% are in hospital cardiac arrest trials. It's kind of interesting because that's where it seems like it'd be a lot easier to study in hospital cardiac arrest. But this is one of the big, I call it a landmark trial for in hospital cardiac arrest. In 2023, Wagner and colleagues published a retrospective study using American Heart Association data, registry data. This get with the guidelines data that is voluntarily reported by hospitals. So they used data from almost 700 hospitals throughout the U.S., patients with in-hospital cardiac arrest with a shockable rhythm that were shocked once and then given either amiodarone or lidocaine. Lidocaine won in every outcome measure. Return of spontaneous circulation. Lidocaine had better 24-hour survival, better survival to discharge, and increased favorable neurological survival at discharge. Some theorize that lidocaine has some pleiotropic effects that are at play here. But nonetheless, this is a retrospective trial, so it has several inherent limitations that come with observational data. I think they did a pretty good job balancing patients and doing some propensity matching and controlling for confounders. But nonetheless, it is what it is. It's a lot of patients, and it is, I think, another signal that lidocaine may be at least as good of an agent for ventricular arrhythmia as amiodarone. All right, so to summarize our antiarrhythmics for ventricular arrest, we have amio and lido. Procainamide, we've talked about it a little bit for stable VTAC. It just really hasn't shown that much benefit in ventricular arrest. Therefore, it's not currently recommended. Amio and lido are both the same exact grade and strength of recommendation in ACLS. So keep that in your back pocket. Like lidocaine's just as a higher recommendation. Amiodarone's a historical favorite. I think a lot more people are used to amiodarone and have trained with it and are familiar with it. There's a multimodal mechanism with amiodarone. Whether this helps amiodarone or hurts amiodarone, hard to say. There's lots of ALPS study sub-analysis. One of the sub-analysis looked at time to antiarrhythmic when the antiarrhythmics were given. Looks like amiodarone was better than lidocaine in the, say, 5 to 15 minute time frame. But recall that lidocaine did show more return of spontaneous circulation at ED arrival. Amiodarone did not show that in the ALPS study. Of course, this was a secondary outcome. Several of the other sub-analysis they've sliced and diced this study every way that they could. They looked at non-shockable rhythms, turn shockable. Lidocaine was superior to amio in that population. Also, while amiodarone worked better than lido in the early time frame, lidocaine had a more durable, sustained action. Lidocaine worked better than amiodarone in the 15, 20, 30-minute time frame after arrest. Recall the one in hospital cardiac arrest trial that showed lidocaine superior to amio in all outcomes. It was pretty impressive. Amiodarone has got a long half-life, and it's got this problematic diluent. It's controversial. Polysorbate 80 shown in animal studies to be what causes hypotension during infusion. It may cause bradycardia also. So depending on how you feel about polysorbate 80, but it is certain that there is no current syringe or vial product available. If you see a vial in your ED or a dosed syringe of like cardiac dosed amio syringe that is free of polysorbate, please let me know, because to my knowledge there is no the only amio products that are free of this polysorbate 80 are in a bag form, like a 450 500 ml bag form, not available in vial. Lastly, lidocaine does come in a convenient dosage form, and the pharmacokinetics are favorable. I say favorable. It just doesn't have a long half-life like amiodarone does. So you don't have to worry about unwanted effects down the road. So exciting, worthwhile talk on ventricular arrhythmias would not be complete without a short section on refractory VFib. This is also known as electrical storm. or also known as malignant ventricular fibrillation or incessant. Lots of different terms to say the same thing. The definition we kind of have come to agree on for refractory VFib is the same definition that they use in these two studies that I'm going to present. That is, a patient who's had more than 3 defibrillation attempts, more than 3 milligrams of epinephrine, and the two studies say more than 300 of amiodarone. I say 450, just because that makes sense. When you've given 3 milligrams of epi, when you've done 3 defibrillation attempts, you've usually given 450 of amiodarone. But that's our definition of refractory ventricular fibrillation. All right, so there are two poorer quality studies that support using esmolol in refractory VFib. This is the literature that we have. So Driver and colleagues in 2014 did a retrospective single center study where they looked at 25 patients. Esmolol resulted in sustained ROSC 2/3 of the time, whether the matching control was only 1/3 of the time. Another group in 2016 did a retrospective single center pre-post study in 41 patients. They found esmolol also significantly resulting in sustained ROSC. Of course, with our larger randomized controlled trials, we don't use ROSC as a primary endpoint anymore. It's viewed as not a patient-centered. We really want to see the full picture when we have a primary outcome, such as survival. We want neurologically intact survival is the gold standard now in resuscitation literature. But again, no improvement in survival to discharge or good neurological outcomes in either one of these trials. But they're preliminary. You'll read both of these trials, and there's been like 2 meta-analysis that feature these 2 trials, and they'll all say more literature needed, more well-controlled, more randomized controlled trials needed in this area, which is certainly true. But esmolol may be a option, and it can be an option. And this is really when we're throwing the kitchen sink at people. The dosing that's been proposed in refractory VFib is the same as esmolol for its label indications. Label indication for esmolol is like rate control and SVT. So it's truly a kitchen sink approach in my mind. But hey, it's worth trying. I've seen rhythms change from ventricular to PEA. I haven't seen ROSC in my career since I've been using esmolol. But hey, it's worth a shot. We give 500 mic per kilo bolus, and then I'll kind of slow code mode it, and by that I mean I'll kind of go get the drip and string it up after we give that bolus, and if we feel like it may be working, then we continue on with the infusion. But certainly the infusion is what is the most common question I get from our medical residents. Do I start an infusion afterwards, or what do we do? And that's how it was studied, so that's how we should do it. If it works, it's probably a sign of catecholamine surge and electrical storm. So that's the dosing for refractory VFib for esmolol. All right, so there's one other optional strategy which has about the same level of evidence as esmolol. It's a procedure totally not essential to your daily practice as a pharmacist, but worth knowing about if you get asked for a local anesthetic like lidocaine in the middle of a code. It's called a stellate ganglion block. These ultrasound gurus with all their nerve blocks in the ED. So it's an ultrasound guided procedure. As you can see, it's technically demanding with like the anatomy, the subclavian artery, the carotid artery, and all the neck anatomy right there, to try to pinpoint the stellate ganglion. The proposed dose is to administer somewhere around 10 cc's of lidocaine or bupivacaine. But the idea essentially is that you block nerve transmission that innervates the heart and delivers epinephrine to the heart, which is going wildly out of control in like electrical storm. So we want to block the catecholamines that are causing this VTAC or VFib. Again, this is for refractory VFib. And this is super cool. The current study enrolling patients right now is called the Gangster VT study, ganglion stellate block for the treatment of electrical storm. And for completeness, here are citations for that one reference slide of all the QT prolonging medications and torsades. And that concludes the presentation on pharmacotherapy of ventricular dysrhythmias. I really hope it was educational and that you can apply some of this to your own practice. Please don't hesitate to reach out to me. Thanks.